All right, so let's talk about some drugs. So, some drugs that we have to know. What I'm going to do is there's going to be the 1As, the 1Bs, the 1Cs. Okay, so 1As. 1As, the first one I'm going to talk about in terms of 1As is going to be procainamide. You know the uses already because you know what 1A actually does. Remember, it only affects the myocytes. And what you need to know about procainamide, I'm going to make it really short so you have like only the highest of the high yields. You're going to be one of those doctors that are going to be a high yield only. But do not despair. Okay, so do not be dismayed by the. All right. Oh, I better cut that out. Okay, so procainamide is the biggest thing you have to know about procainamide is going to be lupus, drug-induced lupus. Okay, make sure you know that one. So here's some tips in terms of lupus. Is this the same as like lupus that you usually get from like the autoimmune disease? No. So how do you tell? How do you tell the difference between a lupus that is autoimmune versus a lupus that is drug-induced? Antihistone antibodies are things that are specifically for drug-induced lupus. So look for antihistone. Okay, so that's the major one for that one. Quinidine. I have to talk about quinidine because it has caught me several times. So quinidine is known for one major side effect. That major side effect is going to be synchronism. Synchronism, because quinidine is originally from the cinchona tree, and then that's where they initially found it from. So synchronism. Okay. So I always forget what synchronism does because it's really confusing. It can give you constipation, but it can also give you diarrhea. It could give you meiosis, but it could cause you mydriasis. It's really weird, but it can be really. It can be described very simply by a muscarinic blocker and an alpha-1 blocker. Yes. Think of it, the way that I think of it is muscarinic blockers. And you know, you use anticholinergics for like motion sickness and stuff like that. I just think of it as like it's screwing around with the same system, and that's how I remember that it causes those things. But the major ones are going to be like diarrhea, constipation, mydriasis, ocular disturbances. So why are there ocular disturbances? But think about muscarinic. Muscarinic makes your eyes small, but if you're blocking it, it makes it big. Okay, so it's mydriasis. But alpha blocker, alpha is supposed to, what's it supposed to do? Okay, so alpha, what does it normally do? It dilates, but now you're blocking it, so it gets smaller. So you can tell that we can't really tell which one it's going to be. It could be random based on the patient. So in terms of synchronism, we just define it as ocular disturbances. They have both alpha blocking and muscarinic blocker. So here's another one that's really, really important. Anything that has like quinidine in them. Are there any other drugs that you kind of remember, like quinidine, antimalarials? How about fluoroquinolone or... Yeah, so there's something really interesting about these drugs. And fluoroquinolones, if you think about fluoroquinolones back in Block 3, one of the major problems with fluoroquinolones is that you can't take them with antacids. Why? Because they're not really well absorbed with antacids. That's fluoroquinolones. That's not quinidine. Can you guess what would happen if you had quinidine, this quinidine, with antacids for absorption? Same exact thing. So whenever you see any drug that has quinidine, quinolone, or anything like that, make sure you know that antacids decrease absorption. This caught me so many times in like RX and shelf and things like that. So make sure you know that one. That's really important. There's another one, discopyramide. It's kind of washed. That one I don't think is that important. Okay, let's go over the 1Bs. One of the important ones for 1B is going to be phenytoin. I'm going to make this chart a little bit bigger afterwards. I know it's kind of like scrunch over here. Phenytoin. Okay, name some important side effects of phenytoin. Okay, gingival hyperplasia. What type of odor reaction is this? Which makes this very unique. The zero odor. So it's possible that they might give you like one of those like charts saying like, oh, it's a zero odor reaction. It doesn't get broken down very. Yes. You would use it for 1Bs. So 1Bs are the ones that shorten it. So if you had an MI, you could use phenytoin in order to realign your heart muscles. You remember the ones that have a really, really long action potential? You can short them again. Lidocaine. That's a good question. I don't know exactly which one is preferred over another one, but they can be used for that use. So, I don't know. So, phenytoin, gingival hyperplasia, zero order. What else? Megaloblastic anemia, right? Megaloblastic anemia. What else? Important one. Don't forget this one. What was that? Yeah, it's P450. I was actually thinking about lupus, but it is a P450 inducer. Okay. Remember the hirsutism. Phenytoin is one of those side effect drugs, so you have to really know the side effects. Do you remember what phenytoin is usually used for? Seizures. Okay. Okay, so let's go to lidocaine. Anything important in lidocaine? I was thinking about more of, there's respiratory depression on this one, correct? That's one of the most respiratory depression. Okay, this one, there aren't many much. There's other like the tocanamide, right, and mexitilin. They might show up, but in terms of the side effects, they don't really show up very much. So I'm just going through the side effects right now. 1Cs, remember what 1Cs is used for? Yeah, they're just like last resort. I'm not going to talk about them so much, but the ones that you need to know is flecainide and telephone. How do you say propofol? Yeah. Okay. Yes?
I've got a question about lidocaine.
Yes, sure.
Maybe this was described somewhere and I missed it, but why is it used for digoxin?
Okay, that's a good question, and I overlooked that because the major use for digoxin toxicity right now is digoxin. So they don't use that anymore. It used to be what they use, and I didn't really think about it too much in terms of the mechanism. I could think about it a little bit, but I don't want to tell you the wrong thing. But they use digoxin for digoxin toxicity now. They don't use that one. All right, so the next one, beta blockers. Okay, here's a really important one. Beta blockers. What is the antidote for beta blockers? Oh no, it's not beta agonist. That's a good idea though, but it's not what they use for beta blockers. Glucagon. I don't think that they stress this enough. I found so many questions on this one. So the antidotes for beta blockers is going to be glucagon. And I don't know about you. That sounds really weird, doesn't it? Are you weirded out by that? I was, but here's a good explanation. So betas. So betas on your myocytes, they are, what type of receptors are they? Oh no, physio. GS, good. So if you know that they are GS, they will usually increase cyclic AMP. Okay? So cyclic AMP goes up, heart goes faster, great. What if you block beta 1? If you block beta 1, then cyclic AMP will go down. So glucagon. Let's think about glucagon by itself. And this goes back to MCP. Glucagon, what receptors does glucagon use? Oh, so that's a tough one. Okay, so remember the glucagon world versus the insulin world? When you're in glucagon, you're like, everything is phosphorylated, and when you're insulin, you're dephosphorylated. Remember that weird thing that we did in MCB too? Well, glucagon is phosphorylated state. How does everything get phosphorylated? Cyclic AMP. So what is the receptors for glucagon? Cyclic GMP. So if you killed the beta blockers, if you killed the beta receptors, which would then decrease your cyclic AMP, how do you increase cyclic AMP? You can use glucagon, and glucagon will raise your cyclic AMP again. So that's why in beta blockers, the treatment for that is going to be glucagon. Okay, so that's an important one. Let's go over some other beta blockers. The only thing that you need to know about beta blockers in terms of side effects and stuff like that. So beta blockers are lol. Okay, so I'm not going to describe too many of them in terms of what their pure names are, but they'll have the lol. And one of the big problems with beta blockers is that you don't want to give them no asthma patients. Why is that? Yeah, beta blockers will bronchoconstrict your patients. So you don't want to use beta blockers for asthma patients. So if you had, okay, so let's make the questions a little harder. Okay, so let's say you have a supraventricular arrhythmia, and then now the patient has asthma. Would you give them a beta blocker or a calcium blocker? Calcium blocker. Okay. So that's the way that they kind of ask you the questions. They kind of ask you, it's like, oh, well, you could use these both, but there's a problem. Can't use them in asthma patients. Okay. Let's go to potassium channel blockers. Yeah. There's also like esmolol and metalol. You can know it by the alol, and I think that's good enough. All right, the most important one out of all of this list that you're going to use in your small groups in ICM and everything like that, this drug comes up a lot. So this drug is going to be amiodarone. If there's one drug that you have to memorize really, really well, it's going to be amiodarone, because amiodarone is considered a really weird drug because it has effect of all the other antiarrhythmics. So I'm not going to draw this because that's going to be really, really weird, but it does everything that all the other antiarrhythmics do. It's called a broad spectrum antiarrhythmic. That means you can use it for any type of arrhythmia that you ever see. So this is the cool thing. When you're in ICM and then you're in the sim lab, and then later on, the person has arrhythmia, and you forgot everything that I told you about like supraventricular, anything that you want. What can you use? Amiodarone. The only problem is that they don't actually use amiodarone that much anymore because they have a lot of side effects. And that's a little bit of a problem. But in SimLab for ICM, remember amiodarone, it'll help you out. Okay, so amiodarone, the side effects are really harsh. So the ones that you have to know is the pulmonary fibrosis that comes along with it. Pulmonary fibrosis is huge. The other thing that's going to be huge is going to be thyroid. And the last one is going to be liver. Those three side effects are very large because they're going to ask you, we just put this patient on a antiarrhythmic, a potassium channel blocker. They're not going to tell you which potassium channel blocker. And they're going to say, what is one of the organ systems that you need to check? And or what are one of the tests that you need to test them for? And one of them will be TSH. One of them, okay, so they won't have more than one of these, but like TSH is huge. They're going to say like, oh, check this, check like ovaries or estrogen or whatnot. Don't pick any of those. Pick TSH if it's there. Pick AST, ALT if it's there. And check whether they can properly breathe. I mean, I don't know if there's actually like a test that they actually do for that, but they will have problems breathing afterwards. Okay, so make sure that you check up on those side effects with amiodarone. It's huge. Okay, other ones that might be important would be sotalol. And the only reason why sotalol is a little bit odd is because not only is it a potassium channel blocker, but it's a long drug, so it has beta blocking activity too. So just be aware that this is also beta blocking as well. And what does that tell you about asthma patients using sotalol as well? Don't use it. Okay. And then the final two that we're going to talk about in terms of calcium is going to be verapamil. Verapamil, also really big in the gingival hyperplasia. And then the other one that does seem to come up is ditalazam. Nifedipine does come up too, but nifedipine is not specific to heart, it's systemic as well. So watch out for that too. Okay. So that's the really quick rundown of all the drugs, and then you have like the different types of side effects with them. And that's it. Do you guys have any questions?